Does competition in health insurance improve health outcomes? In general, consumers benefit when firms are incentivized to improve the quality of their product in order to attract more customers. But when it comes to healthcare, quality can be difficult to observe. Are some insurance plans better than others at improving enrollees' health? These health effects are important, but if they are not easily observed by consumers, then insurers are unlikely to invest in this dimension of quality. This paper studies the Medicare Advantage, or MA, market in the US, and asks whether competing insurance plans have different causal effects on health, and whether consumers are responsive to such differences. To provide some background, the MA market exists within the broader Medicare program, which provides health insurance to elderly Americans. While the bulk of the program is administered by the government, in most places, a beneficiary can choose between traditional Medicare and a parallel set of private plans, collectively known as Medicare Advantage. In 2011, the average county had 19 such plans, and as of 2020, 39% of all Medicare beneficiaries were enrolled in an MA plan. So, do competing plans have different health effects? Using administrative data covering all Medicare beneficiaries between 2006 and 2011, the authors compare one-year mortality rates for plans operating in the same county and after controlling for enrollee characteristics such as age, sex, and race. The resulting distribution shows that there does appear to be substantial within-county variation in plan mortality rates. If causal, these magnitudes suggest that a one standard deviation higher quality plan decreases mortality by 1.1 percentage points. This amounts to a sizable 23% reduction in mortality. But does this reflect causal effects? Consider a set of plans with different observational mortality rates. Part of this variation may reflect that some plans are better than others at improving health outcomes. In other words, plans differ in their causal effects on health, and variation in these causal effects will be reflected in the observed mortality rates. However, part of this variation can also reflect selection. If sicker individuals sort into certain plans, then differences in observational mortality may reflect differences in the baseline health of beneficiaries rather than any causal effects of the plans themselves. So the challenge is to determine how much of this variation is driven by causal health effects and how much is driven by selection. To answer this question, the authors use plan terminations. Terminations force beneficiaries to choose a new plan, and the authors show that when plans with high or low mortality are terminated, their beneficiaries tend to re-enroll in more typical plans. In other words, there is regression to the mean. At the same time, individuals whose plans are not terminated tend to stay in their existing plan. This means that when we compare enrollees in terminated and non-terminated plans, we see changes in observational mortality after the termination. Tracking whether these translate into changes in realized mortality can help us determine how much of the variation in observational mortality is driven by causal effects. To see this, suppose that differences in observational mortality entirely reflect causal health effects and selection bias is negligible. In this case, when individuals move from a terminated high mortality plan to a more typical plan, the actual quality of their plan improves, and this should be reflected in better health outcomes. Conversely, if all of this variation reflects selection and there are no differences in quality, moving to a new plan should have no impact on enrollees' health. And what the authors find is that these termination-induced changes in observational mortality do lead to corresponding changes in realized mortality. In these figures, plans are split into above and below median mortality, but the paper's more generalized results point to the same conclusion. Variation in observational mortality is tightly linked to variation in causal health effects. In other words, this distribution reflects that in the same county and among observably similar beneficiaries, different plans have substantially different causal effects on mortality. This raises the question, do consumers respond to differences in mortality effects? Higher quality plans do have larger market shares, but the results imply that consumers are only willing to pay between $275 and $416 for a 1 percentage point reduction in 1-year mortality. To put this in perspective, conventional estimates of the value of a statistical life suggest this should be worth several $1,000s to the marginal Medicare beneficiary. Thus, consumers are fairly unresponsive to differences in mortality effects. One potential explanation is a lack of information. Mortality effects are correlated with differences in spending, that is, plans that spend more tend to reduce mortality, but they are uncorrelated with CMS star ratings, the most widely used public measure of plan quality. This suggests that consumers may be insensitive to this dimension of quality because they are unaware of it. In conclusion, this paper finds large differences in causal health effects across competing insurance plans. The fact that consumers under-respond to these differences suggests there may be large benefits from policies that shift individuals to high-quality plans, or that make plan-level mortality information more readily available. To read more on this topic, you can check out the paper's references to other related work. These include other papers studying the impact of insurance on health, research on consumers' attentiveness to differences across insurance plans, and finally, papers estimating differences in quality across many institutions, including hospitals, teachers, and schools.